Welcome back to the deep dive. This is where we really roll up our sleeves and take a big chunk of information, could be articles, books, maybe even your own notes, and we properly dig in.
Mm.
The aim, to pull out those key insights, the really crucial bits of knowledge, maybe even some things that, might surprise you. It's all about giving you a shortcut to being properly informed on a topic.
And for this deep dive, we're looking at a very practical guide, actually. It's the book Leadership and Management in Healthcare, a guide for medical and dental practitioners by Stefan Ebla.
Right.
And importantly, this isn't about the clinical side of things. It's specifically aimed at healthcare professionals in the UK, focusing on, well, the leadership and management world beyond the clinic.
Exactly, because, becoming a great clinician, that's one path.
Right.
But stepping up into management, leading a team, running a department, influencing strategy, that needs a whole different skill set, doesn't it?
It really does. You're dealing with structures, regulations, processes, navigating some quite tricky situations sometimes. It often feels like something you just have to learn on the job, perhaps the hard way, over years.
Uh-huh.
And that's where this guide, I think, is useful. So our mission here is to pull out that foundational knowledge from the book, the stuff that perhaps might take you ages to figure out otherwise.
Giving you that essential context.
Exactly, whether you're thinking about a leadership role or maybe just trying to understand the system you're already working in better, or even if you're just curious about how the NHS actually works behind the scenes operationally.
So we'll be covering quite a bit. How the NHS is structured, the different models leaders use to, make things run better, drive change. We'll look at the nuts and bolts of quality improvement, audit.
People management too, job plans, appraisals, revalidation.
Oh, yes, all that.
Yeah.
And then the really crucial stuff around ethics, law, data protection, big topic.
Definitely.
Yeah.
And finally, how trusts actually handle risk, safety issues, those incidents that inevitably crop up.
It sounds comprehensive, the stuff you really need to understand. Shall we dive in?
Let's do it. Starting with the absolute basics, the organizational backbone, NHS structure and governance, as the book lays it out.
Okay.
It traces the history a bit, pointing out that NHS trusts, as we know them now, are relatively recent, really, established under the 1990 National Health Service and Community Care Act.
And then a big change came later.
Yes, with the Community Health and Standards Act in 2003. That's what allowed trusts to become NHS Foundation trusts.
Okay, so foundation trusts. What's the really key difference a leader needs to grasp between a standard trust and a foundation trust?
Well, the book highlights greater financial autonomy and, crucially, local governance for foundation trusts. The idea was to devolve decision-making power.
So moving it away from central government control.
Precisely. Towards local communities and the trusts themselves. They're sort of more self-governing, you could say. More flexibility in managing money and deciding on services.
That makes sense. More local control, hopefully more responsive. The book also mentions the different types of trusts we see.
It does, yes. Breaks it down quite clearly.
Yeah.
You've got your acute NHS Foundation Trust. They run the general hospitals.
Right.
And within that, you find university teaching hospitals, UTHs in district general hospitals, DGHs.
Okay.
Then there are ambulance trusts, community trusts handling things like district nursing, outpatient clinics outside hospitals, and mental health trusts for specialist care.
And that distinction between UTHs and DGHs, that's quite important for doctors and dentists, isn't it? The source goes into that.
It does. Historically, the difference was maybe clearer.
Yeah.
UTH were typically larger, very research-focused, linked directly to medical schools.
Right.
The guide notes that while that university link isn't always as formal now, UTHs still tend to be bigger, often have stronger research backgrounds, larger departments, perhaps headed by academic figures, and they're often tertiary referral centers, handling more complex cases.
Whereas DGHs were traditionally smaller.
Yes, more focused on the general hospital services for the local population, not usually having that direct university affiliation in the same way. Understanding which type of trust you're in tells you a lot about its culture, research potential, the kind of cases you'll see.
Absolutely. It shapes priorities, funding, research, service delivery. Knowing if you're in a UPH or a DGH or, say, a mental health trust isn't just a label. It's vital context for any leader.
So how are these organizations actually governed? How are they steered? The book details the board of directors structure.
And the board has collective responsibility, right? They're all jointly accountable for the trust's performance, strategy, governance, made up of two types of directors.
That's right. You have the executive directors. These are the senior managers, often full-time employees, responsible for the day-to-day running of the trust clinical services, finance, HR, operations, the people making it happen on the ground.
And then the non-executive directors. They seem quite different.
They are. The source describes them as independent. They're paid a fee, not employees involved in the daily grind. Their role is more about oversight.
Setting policy, strategic planning.
Exactly. Providing that independent challenge to the executive team, making sure governance standards are met. They get appraised too. And importantly, in foundation trusts, they're held accountable by another body.
The Council of Governors. This sounds like where that local accountability really comes in for foundation trusts. How does that work?
Well, the guide explains they're made up of people from different groups. Public governors, elected by local residents. Patient governors, elected by patients. Staff governors, elected by trust employees. And nominated governors, appointed by partner organizations like councils or universities.
And they serve for fixed terms.
Usually 3 years, yes, up to a maximum 9, though it can vary a bit.
And their main role is holding the board, especially the non-executives, to account.
Precisely. The source really emphasizes this structure as the mechanism for that devolution of power we talked about. It makes the leadership answerable not just upwards to central government, but outwards to the local community and staff.
So they approve major decisions.
Yes. Things like appointing the chief executive, the external auditors, they ensure the non-execs are fulfilling their oversight duties. Understanding this interplay between the execs, the independent non-execs, and the locally accountable governors is absolutely fundamental if you want to navigate the system or influence decisions within a foundation trust. It's where strategy meets local needs.
Okay, let's step outside the individual trust now. The book also talks about the key national bodies that shape healthcare delivery and regulation. The CQC, the Care Quality Commission, is probably the most visible one.
Oh, absolutely. The CQC is the independent regulator for health and social care in England. They inspect services, they rate them, they make sure fundamental standards of quality and safety are being met.
Their reports have a big impact.
Huge. On reputation, funding, regulatory scrutiny. Being CQC ready is, a constant focus for any trust leader.
Then there was NHS Improvement, NHSI, which merged with NHS England. What was their role?
NHSI, formed in 2016 and joined with NHS England in 2019, its main job, as described, is to support trusts, especially foundation trusts, helping them be financially stable and provide high-quality care.
So helping implement national strategy.
Exactly. Things like the NHS long-term plan, pushing priorities like prevention, mental health efficiency, patient safety. They're the arm that helps trusts deliver on those national objectives.
And maybe one of the most impactful bodies for day-to-day clinical practice is NICE, the National Institute for Health and Care Excellence.
Definitely NICE. Set it back in 1999, is independent, though sponsored by the Department of Health. Its core job is providing national guidance and advice to improve health and social care.
And the source highlights 4 main areas they cover.
Yes, clinical practice guidelines, social care guidance, health technology appraisals, and public health recommendations.
Those health technology appraisals sound particularly powerful, looking at new drugs, devices.
They are incredibly influential. NICE rigorously reviews the evidence. First, the clinical evidence. Does it actually work? Is it effective? And second, the economic evidence. Is it cost-effective for the NHS?
Right.
Based on that assessment, they issue recommendations on whether treatments or technologies should be routinely used and funded by the NHS.
The book uses the Caesarean section guidance, CG 132, as an example.
It's a good one. That guidance provides an evidence base for clinical decisions, helping to standardize practice across the country. It informs commissioners, providers, managers, planning services, even the public about expected care. NICE recommendations often dictate what's available on the NHS. They fundamentally shape clinical pathways and how resources are used. Understanding NICE is absolutely non-negotiable for strategic planning.
The source briefly mentions others too, like the National Quality Board, Health Watch representing patients, and Public Health England focusing on the nation's health.
Yeah, these national bodies collectively set the standards, define priorities, regulate performance, and guide clinical and financial decisions. As a leader, you operate within the framework they create. You can't ignore them. You need to understand their influence to be effective.
So once you've got your head around the structures and the regulators, how do you actually make things run efficiently and drive improvements within that complex system? This is where management models come in, often adapted from other industries, the book suggests.
Absolutely. Managing a healthcare organization effectively means applying established principles. The source discusses several models, different ways of looking at efficiency and change. One that gets quite a bit of focus is the lean model. very much about streamlining processes.
Lean's all about cutting out waste to deliver value from the patient's perspective, isn't it? The book outlines 5 steps for applying it in healthcare.
That's right. First, specifying value. For a patient, that means things like minimal waiting, perfect outcomes, no harm or adverse effects, what they actually care about.
Okay. Second step.
Identifying and visualizing the value stream. Basically, mapping the patient's entire journey through the system: referral, diagnosis, treatment, follow-up. You look at the whole flow to see where the delays or bottlenecks are.
Third is making that process flow smoothly.
Yes, ensuring seamless transitions between different stages of care, different departments, maybe even different hospitals or care settings. No unnecessary waiting or handoff problems.
Fourth sounds interesting, letting the customers pull.
It is. It flips the traditional model.
Yeah.
Instead of the system pushing patients through based on its own schedule, the patient's need drives the process. The example given is departments proactively contacting patients once they're referred, rather than the patient passively waiting for a letter.
Right, pulling the service towards them.
Exactly. And the fifth step is pursuing perfection. That continuous drive for the best possible care, best outcomes, eliminating errors. Lean thinking gives teams practical tools to look at their own workflows in a clinic, on a ward, in theater, identify waste, and make changes to improve efficiency and the patient experience directly. It's very much a bottom-up improvement approach.
The book also introduces the McKinsey 7S framework, which feels more like a diagnostic tool for the whole organization.
Yes, it's more holistic. The 7S's are strategy, structure, systems, shared values, skills, staff, and style. The idea is that for an organization to perform well, especially during change, all these internal elements need to be aligned and support each other.
So if your strategy involves, say, more community-based care, but your IT systems don't talk to each other, or your staff lack the skills for community work.
Then your change initiative is likely to stumble. Exactly. The 7S framework helps pinpoint those misalignments. Maybe the organizational culture, the style and shared values clashes with the formal structure or the established systems. That creates friction. It helps leaders see the bigger picture, how different parts interact.
And leading change itself, that's a huge part of management. The book highlights Cotter's 8-step change model, focusing specifically on the people side of change.
Yes, Cotter's model is really a roadmap for successfully implementing change, designed to overcome resistance and build momentum. The 8 steps, as listed, are quite logical.
Let's run through them. First, establish a sense of urgency.
Make it clear why change is needed now. Then, form a powerful guiding coalition. Get the right people on board to lead the change.
Create a vision, a clear picture of the future. Communicate the vision relentlessly.
Empower others to act on the vision, remove obstacles. Plan for and create short-term wins. Build momentum and celebrate success.
Consolidate improvements and produce more change. Don't declare victory too soon. And finally, institutionalize new approaches, make the change stick.
This is so relevant in healthcare. That urgency might come from performance data or patient feedback. The vision could link to hitting quality targets, like CQINs mentioned elsewhere, and building that volunteer army. Cotter talks about finding those champions who drive the change forward.
Leading change is never easy, is it?
Rarely. Cotter's model really focuses on the human element, getting buy-in, managing resistance, keeping people motivated with early wins, and embedding the change properly. Anyone trying to introduce a new pathway, a new technology, restructure a service, this model provides a really practical framework for managing the people side.
The source touches on a few others briefly, too, which is useful, suggests a broader toolkit. Lewin's model, unfreeze, change, refreeze, simple but classic.
Yes, and the congruence model, looking at how work, staff, structure, and culture fit together. Also the Burke-Lipman model.
That one maps 12 drivers of change and really stresses the impact of the external environment, doesn't it? The book uses examples like a trust changing status or funding model shifting, like from block contracts to payment by results, as external forces causing internal ripples.
Exactly. And finally, Weisbord's 6-box model, looking at purpose, structure, relationships, leadership, rewards, and helpful mechanisms. The point isn't to memorize every model, but to know that different frameworks exist to help analyze problems and plan change. There's no single right way.
This focus on effective functioning brings us right to the core purpose: quality and clinical effectiveness. The source calls clinical effectiveness the umbrella term for the overall quality of care.
And it's not just one person's job. It requires collaboration between different groups in a trust round. Clinical governance teams, clinical effectiveness and research departments, complaint teams, even the confidentiality or Caldecott guardian role.
The process is broken down into three stages in the book. First, getting the evidence.
Right. Pulling together information from NICE guidelines, national and local trust policies, research databases, guidance from the Royal Colleges, understanding what good looks like based on evidence,
Second, implementing change based on that evidence.
which might happen through directorate plans, developing new care pathways, setting up specific quality or safety committees to drive initiatives forward.
And third, evaluating and monitoring. Did the changes work? Are standards being met?
This is where things like clinical governance oversight, tracking patient outcomes, quality improvement projects, and very importantly, clinical audit fit in.
Clinical audit is presented as a key tool feeding into that evaluation stage. The source details the audit cycle, which many listeners will know, but it's worth recapping its purpose here.
Definitely. It starts by identifying a problem or an area where practice could be improved. Then you set clear criteria and standards what should be happening, based on the evidence gathered in stage one.
Next, you observe actual practice or collect data on what is happening.
Then you compare your local performance data against those standards you set. You measure the gap.
And finally, if there is a gap, you implement changes specifically designed to close it and improve things.
Crucially, the book emphasizes that a proper audit needs at least 2 cycles. The first cycle identifies the gap and leads to change. The second cycle involves re-auditing to see if the changes actually worked. Sometimes audits need to be ongoing, and it notes audits must be registered with the Trust's Research and Audit Department.
So clinical audit isn't just a tick box exercise. It's a systematic way to drive real improvement in your own practice or your team's practice. It forces you to measure, change based on evidence, and then prove the impact. It's fundamental for evidence-based care and, of course, for things like appraisal and revalidation.
And speaking of evidence and standards, the source also brings in ethical research and the role of the Health Research Authority, the HRA.
Right, the HRA, set up to protect people involved in research.
Yes, stemming from the CARE Act 2014, it provides a single, unified framework for regulating health and social care research across the UK, ensuring it's ethical and transparent.
They oversee key committees, like the Research Ethics Committees, or RECs.
Exactly. RECs review research proposals to protect participants' rights, dignity, and safety, making sure studies adhere to ethical principles like those in the Declaration of Helsinki. First, do no harm. They also have specialist committees like the Gene Therapy Advisory Committee and the Confidentiality Advisory Group, which advises on using confidential patient information in research.
So if you're involved in research, either doing it or using its findings, understanding the HRA and the ethical approval process is vital.
Absolutely. It's not just red tape. It ensures new knowledge is gained safely and ethically, protecting both the people taking part and the integrity of the findings themselves.
Okay, let's shift focus from processes and systems to the people involved. The source gets into staff management, performance development. Starting with consultants, their role goes beyond just clinical work.
Yes. The book points out their responsibilities in supervising and teaching junior staff, running CPD sessions, and getting involved in local managed clinical networks to improve how healthcare is delivered across different organizations or settings.
And a key management tool for consultants is the job plan, usually set out weekly.
That's right. The source mentions the 2003 consultant contract aimed for an ideal split, about 7.5 sessions of direct clinical care, DCC, patient-facing work, and 2.5 sessions of supporting professional activity, SPA, things like teaching, research, audit, management, professional development.
But it notes a trend towards more DCC now.
Yes, particularly in acute trusts, often closer to an 8 DCC2 SPA split. It also mentions electronic tools becoming more common for tracking time accurately against the job plan.
Understanding job planning is crucial, isn't it? For the consultants themselves, for the clinical leads managing teams, for the operational managers trying to balance service needs with essential supporting activities.
It's the formal agreement on how that consultant's time is allocated. Negotiating and managing these effectively is a core leadership task.
Building on the job plan, we have appraisals and revalidation, described as essential processes.
Yes, the annual appraisal isn't just a chat. It's the formal process for documenting your professional development and demonstrating your skills across all domains: clinical, educational, managerial, research over the past year.
And its main purpose is ensuring you're meeting GMC standards, like good medical practice, and progressing appropriately.
Correct. Appraisals are usually done by a clinical lead or a senior colleague, and the book stresses it should be a two-way discussion. It outlines the typical flow. The appraiser assesses performance, This feeds up to the medical responsible officer, then the medical director, and finally a recommendation back to the clinician.
But the emphasis is on professional development.
Absolutely. The source is clear. Appraisal is primarily about identifying learning needs, setting development goals, and aligning personal development with the needs of the department and the wider organization. It should feel supportive.
And it all feeds into revalidation, which happens every 5 years. The portfolio needed for that sounds quite extensive.
It is. You need your personal details, your current job plan, all your annual appraisal documentation, your personal development plans and reviews showing you acted on them, evidence of probity, often using multi-source feedback, NSF, from colleagues, proof of quality improvement activity like audits or service evaluations.
Significant events, too.
Yes, logged significant events showing reflection and learning, and feedback from colleagues and patients formally collected through MSF. It's quite a comprehensive package.
And the revalidation process itself.
Well, your responsible officer makes an annual recommendation based on your appraisal. The GMC confirms your details, gives you 4 months' notice before your revalidation date is due. The responsible officer submits their final recommendation, and then the GMC makes the decision.
Failing revalidation has serious consequences.
It can, yes. The source lists possibilities for investigation and conditions on practice, right up to potentially using your license. So appraisals and revalidation are mandatory, ongoing processes throughout your career. Understanding the requirements and engaging proactively is absolutely vital.
The book also covers the training environment for junior doctors and dentists, how their progress is managed and assessed. It starts with regulation from the GMC, GDC, and the professional colleges setting the standards.
Yes, the Royal Colleges set the curricula and run the big summative exams, but also oversee formative assessments designed to help trainees learn. Locally, NHS deaneries, or the local education and training boards, LETBs, manage the actual training programs.
And there's a whole governance structure around training within trusts.
There is a director of medical education, clinical and educational supervisors for individual trainees, training program directors for specialties, postgraduate and foundation schools overseeing larger groups, and ultimately the medical director is the responsible officer for all clinicians, including those in training.
How are trainees assessed day to day? The source lists several tools.
Yes. Common ones include case-based discussions, CBDs, focusing on clinical reasoning, direct observation of procedural skills, DOPS for technical skills, clinical evaluation exercises, CEXs, assessing skills in a clinical encounter, and multi-source feedback, MSF or Mini-PAT, gathering views from colleagues and patients on professionalism.
And this all goes into their e-portfolio.
Exactly. The e-portfolio is both a learning tool for the trainee and the evidence base used for formal reviews and appraisals.
Progression is checked formally through things like RITA, Review of In-Training Assessment, and ARCP, Annual Review of Competence Progression.
Yes, and the source notes that ARCP panels now include lay members, which is a GMC requirement to ensure fairness and bring an external perspective.
It also details the foundation program, FY1 and FY2, the first 2 years after qualifying, needing provisional GMC registration and specific approved training posts, especially for FY1, with minimum numbers of assessments required.
It's a very structured system. Whether you're a trainee going through it, a supervisor guiding someone, or a manager responsible for a department with trainees, understanding this framework, the supervision, the assessments, the progression points, is crucial for maintaining quality and supporting the development of the next generation of clinicians.
Okay, let's tackle some of the perhaps trickier areas now. Ethics, law, and data. The source starts with the 4 core principles of medical ethics.
Autonomy, beneficence, non-maleficence, and justice. Autonomy is the patient's right to make their own informed choices about their care, accepting or refusing treatment based on understanding the risks and benefits.
The book uses the well-known example of a Jehovah's Witness refusing a blood transfusion.
Yes, which highlights the practical reality respecting autonomy can sometimes clash with what a clinician feels is medically best, beneficence. These principles provide the ethical framework for every clinical encounter.
Consent is obviously a huge part of autonomy. The source covers it in detail, distinguishing between express consent, clear agreement, verbal or written, and implied consent.
Implied consent is where the patient's actions suggest understanding and agreement, like rolling up their sleeve for an injection.
And consent to release information is critical. You can't share identifiable patient data without permission. The example is using an X-ray for a case report needing written permission and ensuring anonymity. Consent can be verbal, written, explicit, implied, depending on the situation.
Consent for treatment requires providing specific information for it to be valid. You must discuss the risks and benefits of the proposed treatment, Alternatives, the doctor's relevant qualifications or experience if appropriate, and any potential non-NHS costs.
The age of consent is 16, but the source mentions Fraser guidelines or Gillett competency for under 16s who might have capacity.
Yes, and the importance of involving parents or guardians for younger children. It also notes trusts often have different types of consent forms for procedures of varying complexity.
And there are specific consent rules for certain things.
Definitely. The Human Tissue Act 2004 has specific requirements for using tissue samples for storage, research, transplant, post-mortem. Clinical photography or videos need written consent, with levels depending on usage records only, education, or wider publication. And fertility treatments have their own complex consent issues around storage, parental rights, information use. Getting valid consent isn't just ticking a box. It's a fundamental legal and ethical duty. It protects the patient's rights and the practitioner. Knowing the specifics for different situations as the guide details is absolutely vital.
And alongside consent sits confidentiality and data protection, especially crucial now with digital records. The source stresses the absolute duty to keep all patient information confidential.
It lists the key legislation underpinning this. The Data Protection Acts 1998 and the newer 2018 Act. Access to Health Records Act, Human Rights Act, Computer Misuse Act, NHS Act, a whole raft of laws.
But it also clarifies when disclosure without consent is legally required.
Yes, that's important. Situations mandated by law, like for specific public health notifications, abortion regulations, RIDDOR reporting, Road Traffic Act requests, Terrorism Act requirements, certain information sharing regulations. In these cases, consent isn't needed, but patients should ideally be informed, and only the minimum necessary information should be disclosed securely to the authorized body. Police, courts, regulators can also compel disclosure.
The Data Protection Act 2018, incorporating GDPR principles, gets specific attention. Its principles are key.
They are data used fairly and lawfully, for limited purposes, adequate, relevant, not excessive, accurate, kept no longer than necessary, handled according to data subject rights, kept secure, and not transferred outside the European Economic Area without adequate protection. The book notes the 2018 Act tightened rules on international transfers compared to the 98 Act.
And the Caldecott principles are fundamental for handling patient data in the NHS. There are 7 of them.
Yes. 1. Justify the purpose. 2. Don't use identifiable info unless essential. 3. Use the minimum necessary. 4. Access on a strict need-to-know basis. 5. Be aware of security responsibilities. 6. Understand your own duty. And 7. Critically, the duty to share information appropriately for care can be as important as the duty to protect confidentiality.
And trusts have a Caldecott guardian to champion these principles.
Usually a senior person, yes. The source also mentions staff rights over their own data, the need for encryption, special rules for research data, some exemptions if anonymized, ethically approved, and using tools like the Information Governance Toolkit to maintain standards.
The Information Commissioner's Office, the ICO, is the regulator overseeing all this, and organizations handling patient data must register with them.
Handling data correctly is a massive legal and ethical responsibility. Breaches have serious consequences. Understanding data protection law and the Caldecott principles is absolutely essential for everyone working in healthcare today.
Finally, in this section, the book touches on medico-legal issues, duty of candor, and negligence. Duty of candor is about openness when things go wrong.
Yes, it's presented as a formal obligation, especially emphasized after the Francis inquiry. Being open and honest with patients when harm occurs. It links to whistleblowing policies too, encouraging staff to raise concerns.
And medical negligence claims. The book outlines 4 stages claimants need to prove.
First, that a duty of care existed. Usually straightforward between a doctor and patient.
Second, that there was a breach of that duty. This is where it gets complex, involving legal tests.
Correct. The source mentions the traditional Bolam test. Did the doctor act in line with a responsible body of medical opinion? But crucially, it also includes the Montgomery test, or the test of materiality.
Montgomery was a big shift, wasn't it?
Huge. It focuses on whether the patient was informed about any significant risks that a reasonable person in their position would consider important when deciding about treatment. It shifts the focus from just what doctors think is relevant, Bolam, to what the patient needs to know to give truly informed consent about risks and alternatives.
Third stage is proving causation.
Yes, showing a direct link between the breach of duty and the harm the patient suffered.
And fourth, establishing the nature and extent of the harm or damages.
Claims against the NHS are handled by NHS Resolution, which acts like the NHS insurer, funded by trust contributions via schemes like the clinical negligence scheme for trusts, CNST.
Understanding duty of candor, the professional need for openness, and the legal tests for negligence, particularly the patient-centered focus of Montgomery, is vital for accountability, handling complaints effectively, and fostering a safety culture.
So navigating all these structures, people, rules, inevitably involves facing challenges. The source moves on to how trusts manage risk, safety, and incidents. Clinical risk management is defined simply as mitigating risks linked to providing healthcare.
Trusts have policies and systems, often guided by national alerts, to spot problems and stop them happening again.
Exactly. The aim is to reduce the chance of repetition. Risks are identified in two main ways, the book says. Reactively.
Looking back at things that happened, incident reports, complaints, claims, audits.
Yes. And proactively trying to anticipate risks before they cause harm, using risk registers, hazard spotting, staff training, policy reviews.
That proactive approach feels key to safety.
It's fundamental, embedding a culture where everyone is looking for potential problems and feels empowered to raise them.
But when things do go wrong, especially seriously wrong, managing serious incidents, or NICE, is critical. An incident is anything causing or potentially causing harm.
Yes, and reporting them is the first step to learning. For an SI, the process is more structured. Immediate verification, establish facts, ensure patient and staff safety, secure evidence, take immediate action to limit harm.
And these have to be reported nationally.
Yes, onto the Strategic Executive Information System, STACE. This allows the trust and its commissioner, like the ICB, to monitor it. STACE data then feeds into the National Reporting and Learning System, NRLS. Trusts have local reporting systems, often electronic forms, that link into this.
Investigations follow, with different levels.
Depending on severity. The source mentions Level 3 investigations for the most serious incidents, like unexpected deaths, possibly linked to care deficiencies, which often need independent input.
The SI management flowchart shows the steps clearly. Inform the patient family, grade the incident's severity, report it quickly within 2 days, ideally log it on STICE, review the grading with the commissioner, establish an investigation team, conduct the investigation, often a root cause analysis, and submit a report and action plan within the timeframe set by the NHS England SI framework.
The book also mentions never events. These are serious incidents considered entirely preventable because existing national guidance should have stopped them happening, like wrong site surgery.
Understanding this structured SI process from immediate response to reporting, investigation, and learning is absolutely essential for leaders. It's how the system responds to harm and tries to prevent it happening again.
The guide then gives specific examples of managing certain risks, showing the need for clear protocols. One is losing patient-identifiable data, PID.
That's treated as an SI because of the potential harm and legal fallout. The escalation path is clear. Report to your manager, department head, file an incident report, escalate to the clinical director, possibly police if it's theft, and definitely inform the Caldecott Guardian. A risk score needs calculating, and a formal investigation follows a set procedure.
Another specific risk: needle stick injury or exposure to blood-borne viruses for staff. The protocol is very defined. Immediate blood tests for the worker, counseling via occupational health, approaching the source patient for testing, with consent, assessing need for post-exposure prophylaxis, PEP for HIV, checking HPV status for vaccine immunoglobulin, and plan follow-up tests.
The management flowchart details the steps. Assess the worker, assess the source risk, assess the injury risk, arrange workers' bloods, assess need for PEP HPV prophylaxis, consult infectious diseases if necessary, administer prophylaxis quickly, arrange follow-up, get anonymized source results, review ongoing needs. It's reported via incident forms like GITICs and involves occupational health and safety.
A third scenario covered is violence and aggression at work. Strategies mentioned include risk-assessing environments, staff training and de-escalation of managing behavior, improving waiting areas, clear communication, staying calm, managing reception effectively.
The flowchart shows the response. Recognize potential aggression, try to de-escalate or remove the threat, call security, ask person to leave, document it formally via an incident report, inform managers, potentially involve police, and maybe the legal department if formal action follows. Outcomes vary from resolution to legal proceedings or compensation via NHS resolution.
These examples, data breach, needle stick, violence, really highlight the need for clear, practiced protocols involving multiple teams. Occupational health, security, HR, legal. Managing risk isn't abstract. It needs concrete procedures to protect people when specific incidents occur.
Okay, moving towards broader operational management now. The source covers things like managing staff absence, stress, finances, and integrity. Absence management is a common headache for leaders, requiring knowledge of different leave types.
Yes, the book details various entitlements. Maternity leave, statutory and occupational pay and leave, maternity allowance rules around keeping in touch days, paternity leave, again, statutory occupational options, shared parental leave, study leave, funding rules, application process, reimbursement limits, usually non-transferable budgets.
Also, emergency leave for unforeseen dependent issues, usually a couple of paid days, then manager discretion for annual unpaid leave, special leave for bereavement or caring responsibilities with specific rules on paid unpaid days, eligibility, and trade union leave for official duties.
Knowing the basics of these is important, but the real challenge often comes with managing repeated short-term sickness absence. The source discusses using the British Sickness Score, or BSS, for this.
The BSS formula highlights frequency over duration.
Exactly. It's the number of separate spells of sickness squared times the total number of sick days, D, in a set period.
The example given, 5 episodes totaling 25 days gives a BSS of 5 squared, 25 times 25 times 25 is 625. High scores trigger investigation.
Yes. The book suggests common triggers might be a score over 128, or perhaps more than 3 episodes in 6 months. Management follows a stepwise approach: observation, reporting, fact-finding, then informal discussion and support, with clear documentation.
Formal stages only kick in if things don't improve.
Right. Involving HR, potentially leading to warnings, a formal hearing, and possibly dismissal on capability grounds if absence persists despite support, with appeal rights. The book stresses understanding underlying causes first and using formal processes as a last resort. It's a tricky balance between support and ensuring service delivery. Managers need to know the BSS and the formal procedures.
And linked to absence, often, is stress at work. The source flags this as a major issue in healthcare.
It lists potential warning signs for managers: multiple short sickness spells, more incident reports, high staff turnover, lots of vacancies, excessive overtime, breaching working time rules, poor staff survey results, low patient feedback scores, poor team attendance or outcomes. These could indicate underlying stress problems.
Support is available from various places.
Yes, the employer, occupational health, GP, line manager, HR, health and safety advisors. Staff have the right to keep medical details confidential from their line manager if they wish.
Managers have specific responsibilities here.
Yes, implementing the trust stress policy, doing annual workplace stress risk assessments for their area, and completing individual stress risk assessments if needed, after self-referral, GP note, or OH advice.
The approach to managing a stressed colleague is also stepwise. Gather evidence using those indicators, work with health and safety to identify workplace risk factors, complete risk assessments, team and individual, analyze trends, create and implement an action plan to reduce stressors, and then reassess.
Recognizing stress signs, knowing the support routes, using risk assessments and action plans, these are vital leadership skills for well-being, performance, and keeping staff in demanding roles.
Let's touch on finance and resources. The source explains making a new business case in the NHS.
Essentially, it's how you formally justify needing investment for a new kit, a new service, or, as in the example, a new staff member. It's arguing the case for resources based on need and benefit. Templates vary, but the purpose is the same.
The key stages outlined are: identify the need clearly, find the right trust template, discuss the rationale with stakeholders, head of department, clinical director, finance, get it approved by relevant committees like clinical effectiveness or governance, then get final sign-off.
A typical case includes an executive summary, the short pitch outlining the need, solution, and benefits, like income generation, improving training, succession planning, followed by detailed background information backing it up.
The book also mentions ways trusts might try to increase income.
Yes, things like reviewing referral thresholds, ensuring correct coding for income, running courses, private patient work, charging for damages, research grants, overseas visitor payments, commercial income from parking, catering, etc.
And cost-cutting measures on the pay side.
Revising staff numbers, reducing temps locums, early retirement schemes, job freezes, changing the skill mix.
For any leader, understanding resource allocation, how to build a strong business case, and contributing to financial sustainability, whether getting investment or finding savings, is crucial. It's where clinical needs meet the bottom line. Finally, the source covers upholding standards and integrity, dealing with tough issues like suspected fraud and health tourism.
Right. If you suspect fraud, say, discrepancies in payments or resource misuse, The book says reported to your manager lead, but also, critically, to the trust's dedicated local counterfraud specialist, LCFS.
Escalation might involve the board, police, IT, HR, and whistleblowers are protected.
Yes, the Public Interest Disclosure Act 1998, PIDA, protects those reporting genuine concerns about wrongdoing, like fraud. Organizations like Public Concern at Work offer advice. Fraud is defined broadly: dishonest acts, bribery, corruption. Reporting suspicion is an ethical and legal duty to protect NHS funds and public trust.
And the issue of managing patients not entitled to free NHS treatment health tourism.
The book tackles this, referencing trust policies. It starts by restating NHS principles: universal access based on need, free at point of delivery. But eligibility for free care usually depends on being ordinarily resident in the UK.
Non-EEA nationals staying long-term often pay the immigration health surcharge.
Yes, though there are exemptions. The process for managing overseas visitors via A&E is outlined. Clinical assessment first, then inform the overseas visitor officer, OVO. The OVO assesses entitlement, confirms funding payment, and the trust decides based on urgency and payment ability following a flowchart.
For outpatients, the OVO checks documents, sorts finances, takes payment, or if refused unable to pay, the clinician judges urgency. Some services like A&E, if not admitted, and family planning are exempt from charges.
Patients from EEA countries are more complex, involving EEG cards for temporary necessary treatment, S1 forms for those whose healthcare is funded by another EU state, like pensioners, and S2 forms for planned treatment abroad. There are also specific rules for students based on visa type and stay duration. Navigating eligibility is a practical management issue. It impacts patient flow, finances, and needs careful adherence to complex rules and policies. Leaders need awareness of these processes.
Wow, we really have covered a vast amount of ground there, drawing from Stefana Bella's guide, from the fundamental NHS structures and governance through management models for efficiency and change, quality improvement, and audit.
People management aspects like job plans, revalidation, training structures,
Yeah.
then the critical areas of ethics, law, data protection.
And finally, how trusts handle risk, safety, specific incidents, plus those broader operational challenges like absence, stress, business planning, and integrity.
It really does highlight, doesn't it, how much more there is to healthcare leadership than just clinical skill. It requires this deep understanding of a really complex system: the structures, the rules, the tools for improvement, your responsibilities to staff, the processes for dealing with difficulties.
And this deep dive hopefully has given you that foundational knowledge, taking a lot of dense information and making it a bit more accessible. Because this isn't just theory, is it? These are the real-world systems and challenges that affect how you practice and lead every day.
Absolutely. If you found this deep dive helpful, please do consider rating and sharing it. It helps other people find these insights too.
And maybe a final thought to leave you with. In this really intricate web we've explored, where structures, rules, people, and pressures all intersect, what single aspect of this non-clinical leadership landscape do you think is the most critical for the future health and sustainability of our healthcare system? Something to ponder.